It's been a fantastic meeting, and look, thank you for inviting me. And I've sat in the audience as in my moonlighting capacity as a clinical trialist, and I've thoroughly enjoyed the talks, and it just proves you're never too old to learn things. So I don't have really any significant disclosures, but I will just mention one thing. But I'll firstly acknowledge the Darug people, the traditional custodians of the land in Western Sydney, who gifted us with the name Gumal, which means working together for better health and well-being. So it's a partnership message that is really what these centres are all about. And I was asked to talk about the AHRTCs and how they might have a role. The AHRTCs are just one component of this new ecosystem. They're also Centres for Innovation in Regional Health that have a pretty well an identical mission. So I'll just sometimes use AHRTCs, but I'm talking about both the centres. So my only disclosure is I'm grateful to Jeremy Grimshaw here for enlightening me many years ago on the moving from the sort of drug trials world to the world of systems and complex interventions. And Jeremy has been a great colleague and a mentor in that space. So I have dabbled in that space, and I was fascinated by the things that we just heard. So clinical trials, this is my own personal perspective. Some of you will realise that is not a sea horse, but it's a sea dragon. And they're even more sensitive than sea horses to the environment. And I really think that trials and research particularly in that context inside healthcare is really the litmus test for the quality of your ecosystem, much like these are a litmus test really for the quality of our environment. And if we are able to really grow this enterprise and strengthen it, then I think we're doing a noble thing. We're doing a good thing for our patients, and of course that's the ACTA Alliance, the Australian Clinical Trials Alliance mission, which you all know, which I read, of course, before I came down to speak. And I think this is really where these new kids on the block, these advanced centres, can really now work in broader partnership as we set them up. But they're very new, and I'll give you a bit of a flavour for what I see from my lens as a clinician coming through research training, clinical trialist, leading one of these centres now, and what the value proposition is. Now, the genesis of these centres was the McKeon review some 5 or 6 years ago now. But of course, for many years before that, other parts of the world were running academic health science partnerships, and the concept of sort of linking in partnership the research world, healthcare world, and the community. And of course, clinical trials is a cornerstone of all of that. Of course, we're driven really by economic imperatives around the growing cost of healthcare and the move towards value-based care and trying to improve sort of return on investment in research. And in our system and many others around the world, the other real driver or the issue really underpinning these AHRTCs is to try and, I guess, massage our system a little so that we reverse this sort of malalignment of system drivers that we face in our system, where our hospitals, our universities, our medical research institutes and primary care all are being pulled in different directions by the drivers of their performance. And the idea here is we can begin to turn things around a little bit and try and get some alignment of purpose through what I think is a reasonable proposition and I think a plausible hypothesis. So this alignment piece is what the AHRTCs are all about, really. I'll come back to the how in a minute. Now, the UK have been doing this for a long time, and they've put in multiple structures, as you can see here, to try and sort of develop this sort of connectivity between the academic sector and the healthcare delivery sector. And we've learnt quite a lot from that, and we'll continue to learn from that because they're evolving their sort of system of academic health science centres, clerks, networks and research programs feeding into that. And I won't dwell on that, but this is a complex ecosystem in the UK, and it's going to become equally complex here, I think. And there is still an ongoing debate as to whether this is working. and this is still an open debate there, and they've been running these centres now for, in highly invested centres. We're talking about, tens of millions of, even hundreds of millions of pounds invested for many years, and there remains conjecture. It's just a summary. You can read there of some of the erudite assessors of the effectiveness so far of the UK Academic Health Science Centre and network concepts. So in Australia we're about 4 years old, but in Australia there's been minimal investment so far in these centres. So we have gone through a rigorous accreditation process with NHMRC to ensure that we have the goods, and I'll talk about that in a minute too. But what these centres are really large-scale consortiums that have a major population base underpinning them. The metro centres around 2 to 3 million, the regional centres around 500,000 to 1 million. They have massive research engine rooms, these centres, particularly the metro ones. And I think in the regional centres, the unique challenges of healthcare delivery and translation in regional and remote, which is really a key issue for this country. They're supposed to develop programmatic translational enablers. So that's really the role for these centres, and at the moment it's a bit of an all-in brawl, I must say. We're still sorting ourselves out and working out how we can work effectively with our absolute key stakeholder. But there is a genius potential here, I think, and that's because these centres are led by senior health service management, and they cover the translational impact pipeline. So we're trying to get the engagement, the buy-in, the pull by healthcare into the agenda here that we're trying to promote. So this is really, I think, the main message I'm going to give you, that there's promise here, that we can probably change our culture a little bit. The NHMRC accreditation criteria, I won't bore you with that, but I actually established the New South Wales Regional Centre and then jumped ship and jumped the Hawkesbury, went down to Sydney. They're the deliverables that we had to present to NHMRC as to our potential to really get things done, and item 3 and 6 are probably the most relevant elements we had to prove our potential to deliver on. And this is, as I see it in this country, this is my sort of concept of how these AHRTCs look. So we've got our traditional research engine rooms that are driving great quality work in this country, and we punch well above our weight, as we know, in the discovery and the early phase space. And then we have our translators in hospital, primary community care and population health. And the AHRTCs and the centres are really up that end of the spectrum. We're there to try and help that sort of definitive applied testing and adoption and diffusion end of the spectrum. And when I look at it myself, and again, it's another one of my crazy mock-ups. I mean, I coming from 20 years as a clinical neurologist and then developing my academic world, I'm still very orientated to what the patients are going to get out of all of this. I think the AHRTCs and the CIRHs can bring together the health services and the academic groups into the middle of this. That's what they're trying to do. But more importantly, they can actually network across large areas, bringing stakeholders together with a common purpose. And I think also network across the country, which I'll show you. And this is where I think the opportunities are for ACTA and the AHRTCs to work together. And I know there's a conversation already developing, and this will evolve, I think, pretty quickly through the course of the next 6 to 12 months. But the key, as I'll come back to, is that for these centres, the health chief executives, the general management of the hospitals, they are there and they are calling the shots. Now, they don't quite know yet how to call the shots, and we're working with them gently and cautiously to I guess, dispel the not uncommon sort of feeling amongst health service management leaders that the academic world, what's in it for them, can be parasitic. Is it going to really benefit us? What's the value proposition for us? And this is really a bit of a culture change piece, I think. Personally, I've done this at the sort of lower levels, building things, and I'll come back to that sort of philosophical point, we're now trying to do it at the very upper levels across entire states, getting them engaged. So what can they do? I think the AHRTCs and the CIRHs are enablements and facilitatory vehicles to get alignment of purpose, to embed senior health service management sponsorship and funding of research. So that healthcare dollar, to have some of that spent programmatically. Now, of the 9, there are 9 of us across the country. I'm in the position, and in fact why I jumped to Hawkesbury was because Sphere is the biggest invested partnership. So Sphere has put $25 million into its operating budget over the next 4 years to drive some programs. The MRFF has trickled through a little bit. There's some project money, but we all know that project money's of variable use in this space, so we need to be driving things a little bit more programmatically, and Sphere is able to do that. So I'll tell you what I'm doing. The second dot point, accountability is key, and we're still working on the accountability piece inside health management. You've got to be gentle with the health managers. You've got to allow them to see that this is not beyond them, and that research really can be delivered, and their metrics are not challenging. And working in partnership, of course, that's the key to it. And in New South Wales, we're beginning to build relationships there with our local ministry. Our New South Wales ministry is very keen on clinical trials support. They have a framework they want to roll out. We'll help them with that. We want to work with ACTA. We want to work with MTP Connect and other groups. So my personal reflection, and this is from my years of sort of banging away, bottom up, trying to drive clinical trials. Generally, the high-performing trials groups, hospitals, units are led by what I call the trial evangelist or the entrepreneur, who's able to do this. They're driven people, they get in there, they get grants, they get funding. Generally, they finance it all from their own efforts, and there's not much investment coming to them from other sources, and they manage up quite effectively. But this is not programmatic, it's patchy, as we know, and this is why ACTA exists, to help bring this and lift it, and why all you are here, to try and enable and grow this. And it's really a labour of love, I think, amongst all the converts here in the room, I'm sure, and others. But I think the really programmatic elements are variably accessible. They're not well organised all that well across regions. Certainly larger scale regions are not well covered by programmatic trial support. And we need to do more in that space. So how can the AHRTCs help? Well, I think the 3 things, noting I'm between you and lunch and I won't take too much more time, but the three things are leadership with healthcare setting the priorities. That will engage and will begin to do some of the things we heard about here in discussion about some of the enablers to translation, the co-design pieces, the ability for that priority setting to occur and from there to be real stakeholders in the process. Partnership funding. These partnerships need to invest internally, and I think the others are following suit across the country. So there's money around, and they need to begin to invest it. Not only the unis, but the healthcare organisations as well. And then we need to have some programmatic approaches, and I'll show you what I'm doing in Sphere. So Sphere's constructed fairly traditionally, if you look at academic health science partnerships around the world with clinical academic groups that are cross-disciplinary, cross-geography, cross-institutional, running sort of usually rafts of projects. And then I'll put aside that a number of enabling and support platforms that are injecting funds into the project world that the clinical academic groups run, and one of those is clinical trials support, and this is just beginning to form. It's forming around this state-based, some of you would have seen this if you're from New South Wales, the New South Wales Office of Health and Medical Research Clinical Trials Support Unit framework that essentially provides guidance around some key elements that we know are important for lifting performance and allowing the sort of the art and science of clinical trials to move from the ivory towers of those really hot, high quality research-intensive clinical services in hospitals and primary care, more difficult there, of course. Diffuse them, grow them, spread them out across the sector inside your centre. So what I'm doing in my plan, and I put some money against that over the next few years, is to really begin to get some proof of concept for some large-scale support for design methods analysis, some large-scale support for conduct and recruitment, some large-scale support for improving the financial management of the trials, and also some support for the sort of external-looking, bringing business in, brokerage sort of concept for trials across sphere. So this is all seed money. This is not a lot of funding, of course, and it's as much as I can afford, but it's there, I think, to begin to see whether we can begin to move forward here at scale, move from the cottage industry that is clinical trials in most hospitals into a more programmatic approach. Now I'll finish up just talking about this alliance of 9 centres. So there are 7 AHRTCs and 2 Centres for Innovation in Regional Health spread across the country. And I think if I was going to summarise what they can do, they really are there to support national networking. That is their role, and they need to be supporting ACTA and other groups who are forming these national networks in other areas outside clinical trials. At the moment, they've got some funding to do 4 programs of work around systems improvement, Indigenous health, better use of health data, and consumer engagement. This is a small amount of Medical Research Futures Fund money that's come through to them. And you can see we've divvied up the work and we're all working together across the AHRTCs. The AHRTCs cover 90% of the sort of academic landscape of the country now. So we've got the intellectual capital within these groups, not necessarily the co-chairs, but I'm talking about the steering committees and all the other people that come together to form these groups. So the group that I'm leading is developing a national framework, yet another one. Someone's toothbrush, I think Sally said that, someone else's toothbrush. And it's still in draft form, it's not gone out yet. We've spent the last 6 months working on it, just to look at how we as a group of advanced centres can help the joint mission around trying to uplift not just trials, but the broader elements of right through to implementation, quality improvement, etc. And I think what we're looking to achieve is really test this novel, new approach for Australia, develop an approach where our members coordinate investment. We would like to do that and try and help uplift our clientele within these AHRTCs, and in partnership look at what we can do to support implementation of best evidence practice, value-based healthcare and quality improvement. So I'll finish up. So that's the Sphere mission. That's the swathe of southeast, southwest, central Sydney that I now oversight. My 3 unis, 7 research institutes and 4 health services. So I'm really, it's a great pleasure to talk here, because I think over the next 6 months between ACTA and the Australian Health Research Alliance, the alliance of the 9 centres, we can really pick out some things that we can do together and work carefully on, assuming we can leverage a bit more investment. So thanks, Steve.